Just amazing, amazing. So we're almost ready for lunch, and I think before we break for lunch, we should talk about fecal transplants. Don't you think that would be a fine thing to do?
You don't want to talk about it after.
Well, anyhow, it's on the schedule, and it gives me a great deal of pleasure to introduce Dr. Brett Lashner, who knows a thing or two about that.
Thank you. Okay, yeah, you don't want to hear this after lunch, believe me. Okay, so fecal transplantation is what we're going to talk about. You read it in the Plain Dealer. It's a very hot topic. Right now, it's only used for Clostridium difficile, C. diff infections. And I'll tell you our experience and the reason why it's C. diff. But in the near future, it will be used for ulcerative colitis and possibly for Crohn's disease, which some of you may suffer from also along with your PSC. So let's talk about the history of fecal microbiota transplantation. FMT goes way back to the 4th century. These were studies done by Dr. Carey himself. In hieroglyphics, you know, where an oral fecal suspension, fecal feces called yellow soup from a normal person was given orally to people with severe diarrheal diseases, and indeed, they got better. Same thing happened in the 16th century China. Fermented fecal solution treated fever, severe diarrhea, vomiting, constipation. I'll show you in a minute how well it works in veterinary medicine for sick horses and cattle. The first fecal transplants for pseudomembranous colitis, another name for Clostridium difficile, was done in 1958 with an enema preparation with a dramatic response in 48 hours. Of course, we don't use yellow soup anymore. We have our own yellow concoction that cures everything, and you all know what that is. It's the cappuccino, of course. In veterinary medicine, it's called transfaunation. If you have a horse with diarrhea, those of you who have horses probably know this. If you infuse stool into the colon from a healthy horse into a sick horse, the sick horse gets better. Cattle really don't mind eating stool. Think about that next time you have a piece of meat. And a sick cattle will eat by mouth as rumen, normal feces, and indeed they get better from the diarrheal illnesses. So what about the human intestinal microbiome? This is now becoming one of the hottest topics in medicine because it's associated with everything. I'm going to show you a lot of things it is associated with, and keep your eye on this literature. It'll be in the lay press. It'll be in the medical literature. The GI tract, as you can see, is virtually sterile through the stomach and small bowel, but when you get to the colon, you have 10 to the 9th to 10 to the 12th bacteria in the colon. In fact, there are more bacteria in your colon than cells in your body by a factor of 10. You are mostly bacteria. And the microbiome, the composition of that bacteria, varies depending on which area of the world you live in, your age, your diet. In fact, the best diet for the best fecal flora are vegetarians. What does that say? Herbivores. Yeah, herbivores on the right have the best diversity. Carnivores, meat eaters, have the worst diversity, and most of us in the middle have middle diversity. But you know, when you're thinking, who are you going to have for your donor, it'd be really nice to get a vegetarian. You also don't want someone very young or very old. The diversity goes down in the very young and in the very old, and in people who are sick, who have chronic illnesses. You see in the red there, people have a lower diversity when you're sick. When you get healthy, you go back up to normal. So you want a nice middle-aged person who is not chronically ill. So what is fecal transplantation? What it is we take stool from a healthy person, mix it up in non-chlorinated water, and infuse it into the colon of a sick person. to treat a certain disease. And I'll go through the exact formula we use, or what our protocol in a minute. And the rationale is disease is caused by dysbiosis, or a perturbation of the bacterial flora. And if we can restore the bacterial flora back to normal, the disease will go away. And indeed, I'll show you some data that it might. Now, there's a literature developing on all of these conditions. They're all very diverse, and you can say, how can this be related to the fecal flora? We don't really know, but it is. I mean, look, multiple sclerosis, obesity, type 2 diabetes, heart disease, hardening of the arteries, inflammatory bowel disease. You see there in blue. Blue means it's being studied right now. Green means there have been randomized clinical trials to show that it works. So in type 2 diabetes, insulin resistance, it works. Probably works in fatty liver disease. You don't see PSC here, but you do see inflammatory bowel disease, which is associated. At the end of this talk, I'll talk about the really interesting data coming from the Cleveland Clinic on atherosclerosis, how changing your fecal microbiota may help you prevent heart attacks. All right, so the disease that I need to talk about, because that's what we're allowed to do it for, is C. difficile, Clostridium difficile. If you have C. difficile and ulcerative colitis, you can get a fecal transplant. If you have ulcerative colitis and no C. difficile, you can't get a fecal transplant. So C. diff is the linchpin. It's you see in the yellow there the bacterium, but the most important thing that it spreads is the spores in green. It is rampant at the bottom. You see this exponential growth of C. diff cases related to hospital stay, hospitalizations, antibiotic use, institutional. All of the doctors here carry C. diff, I'm sure, on our white coats. We are supposed to, and we do, wash our hands very, very, very frequently, but still C. diff just is rising and rising. And it's a very important public health problem. This is what it looks like when we do colonoscopies on people with C. diff. Those white mucousy things are called pseudomembranes. Another name for this is pseudomembranous colitis. A lot of times we can diagnose this right at colonoscopy. We say, oh my gosh, pseudomembranes. But we will send for culture and confirm things. And that sometimes it can get very severe. And indeed, with pseudomembranous colitis, you can lose your colon. You can get fulminant colitis that progresses, and it might kill you if you don't have your colon removed. What more frequently happens is we diagnose C. difficile, we treat it, and it just keeps coming back. About 20% of patients relapse, and it relapses and relapses and makes your life miserable. And we have some very unhappy patients who come see me for this fecal transplantation. Why do people, and there's no real universal algorithm on how to treat these things. So why do we get it? Well, some strains are more virulent than others. If your host response is impaired, if you're immunosuppressed with medications following liver transplantation, even proton pump inhibitors like omeprazole are associated with C. diff. Somehow, if you can't clear the infection from your system, you will get dysbiosis and could get C. diff. Here are some other risk factors for Clostridium difficile: age, greater than 65, immunosuppression, organ transplantations, chemotherapy, steroids, HIV, IBD, end-stage renal disease, end-stage liver disease, proton pump inhibitor, hospitalizations, or any kind of stay in a long-term care facility, and a previous history of CDI. How does it work? Well, what's happening in the bottom circle is the disease just keeps coming back. Now, I'm going to put this brown, smelly liquid in the colon of that person that will break that vicious cycle, and then they go around up there, and they get a nice, healthy colon that looks like that. And I should tell you, some of my most grateful patients are the C. diff patients who have C. diff. They're so happy that I bring them in front of the medical students to show off a little bit. And I say, oh, we love you, doc. You saved my life. You're the best. So, I mean, this is really happy medicine. We are going to be doing this more and more as doctors as time goes on. Does it work for C. diff? Yes, it does. I'm going to go through this very quickly, but here's a couple of studies 20 studies that looked at 536 patients with about a 90% success rate. And compare that to what antibiotic like vancomycin, 30%, you can see huge difference. This works. The others really don't work that well. So here's our protocol for FMT at the Cleveland Clinic. We get insurance approval for the whole package. This is deeply discounted. We have yet to have a insurance disapprove of this in the appropriate patient. So it's all free, if you get insurance approval. We use IRB informed consent, IRB approved informed consent, and we ask the patient to choose a donor. Donor, of course, has to be healthy. They typically use a spouse or partner or relative because they trust these people. They know they're not doing risky behaviors, or they may not have they'll probably be okay. Donor exclusions: antibiotics within the first 3 months. Within 3 months. History of GI problems: diarrhea, constipation, inflammatory bowel disease, cancer, immunocompromised. These people have to be in good shape. We test the donor stool. We don't need to test the recipient stool anymore. Make sure they don't pass any pathogens on. We do test the donor and recipient for diseases that could be communicable, like hepatitis, syphilis, HIV, or its cousin, HTLV. Excuse me. So the night before, we give the donor a gentle laxative, so they make sure they have a bowel movement the next morning. We actually did have a patient who took the laxative, a donor, and couldn't poop in the morning, and we had to reschedule. The recipient was not happy. We asked them to do the preparation, mix it with non-bacteriostatic water, which we give them. They filter it, take out all the chunks, give me the stool, and we use it relatively quickly within a few hours. The recipient, just like a colonoscopy, they take a big prep and go out with the old before we go in with the new. And this is what it looks like. This is what we do. We put the stool fluid in syringes and inject it in the right colon. The whole procedure takes about 15 minutes. It's really quick, and patients are very, 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 very well sedated. We do, because I want them to sleep for 3 or 4 hours. I don't want them to wake up and run out of here. So we do gown and glove and mask in case there are any splashes. There's only been one. That was our fault. But this lady over there on the bottom right is having a mask over her neck. I have no idea why she's doing that. It's not what we do. The person she's doing with Dr. Carey. Where's Dr. Carey? It's hard to make fun. That's the great Dr. Larry Brand. Who came here to visit and tell us about this about a year ago. So he's at Montefiore Hospital in the Bronx, New York. So what are our outcomes? I personally have done 114 now in the last 2 years. With Cleveland Clinic, Florida, our protocol is well over 150, 96% success rate. Mostly everybody that we repeat testing, they're still having diarrhea or C. diff negative. So we're virtually assuring people we can get rid of the C. diff. Not necessarily the diarrhea, but it's really good. Other people have asked patients, if you had to do it all over again, would you do a fecal transplant or do the antibiotic route? And they all want to do fecal transplants. Cost effective, it's way cost effective compared to these expensive and not so effective antibiotics. Okay, so that's it for C. diff. It really works. Now, what's the data on ulcerative colitis? Many of you in this room have ulcerative colitis. Should you be considering this? So the reason why people get ulcerative colitis is very complex. There's a defect in the immune system, and some bacteria are involved, loss of tolerance, But if you look at the bottom left, dysbiosis is really important. There's some protective bacteria, and you need commensals to keep those, you need good commensals and good protective bacteria, and there's a dysbiosis in ulcerative colitis. So what happens is a normal colon looks like this, but with dysbiosis or whatever triggers a flare of ulcerative colitis, you get something like this. Okay, next. And this is the theory behind what happens in ulcerative colitis. This is also about 25 years of research distilled into one slide. On the left, you have what the normal response is to bacteria in the colon, where we have defensins in the base of the crypt that kill off these unsuspected bacteria that happen to get into the crypts, and everything, the immune system is there to protect you and to keep you healthy. So normally, we do have an active immune system that is good to protect you from bacteria that get in the wrong place. The immune system in people with ulcerative colitis is different. They may have a decrease in defensins, can't fight off these bacteria that slip into the crypts. They activate the immune system the whole wrong way that goes crazy and causes lots of inflammation. And that's one way we think of Crohn's disease and ulcerative colitis as developing. It's similar to what we said here, decreased diversity, and okay. So there was a randomized clinical trial from Paul Maietti's group at McMaster University in Hamilton, published recently in our main journal, Gastroenterology, that took people with ulcerative colitis and no C. diff, gave them fecal transplant via enema from an anonymous donor every week for 6 weeks versus placebo enema. Okay. This was a negative study. Even though there was more remission, you see there with a p-value of 0.05, the primary outcome was the disease scores, like the Mayo score and the quality of life score, and they were no different between groups. And he called this a negative study. The trial was stopped early because it was futile. But when he looked at the data more closely, he found a very interesting phenomena, that donor stool matters. All donor stool is different. See, A, B, C, D, E, and F are all different from each other. But anyone who got donor stool B got better, reliably and predictably. Of course, he is not letting out the name of donor stool, donor B. But I'll bet if you want a fecal transplant for ulcerative colitis, you could go to Hamilton, Ontario, and you might get donor stool B. If you do, ask for donor stool B. But that is really the key to figure out the right probiotic combination that works. And it does exist. We're just not smart enough to figure out what it is yet. So what about other studies? I'm just going to go through this very quickly. It's really mixed results, not really that... not that convincing that it does work. But there's a work here that's very interesting that I just want to tell you about for the fun of it. On atherosclerosis, or hardening of the arteries, and how it relates to fecal dysbiosis. There's lots of grants going to a researcher here named Stan Hazen, who has found that there is a link between a chemical in the colon called TMAO, trimethylamine oxide, and atherosclerosis. Now, TMAO is made by the microflora. If you eat phosphatidylcholine, which come from eggs, meat, cheeses, lobster I see there, it gets metabolized in the gut flora to choline. It gets metabolized somewhere in the GI tract to choline. The gut flora makes TMA, and further on TMAO, trimethylamine oxide. And that leads directly to heart attacks. And indeed, here's TMAO as a linchpin for not just heart attacks, but they're claiming it's good for liver disease, ulcerative colitis, Crohn's disease, lots and lots of stuff. If you can put in bacteria that prevent the development of TMAO, you might be able to cure a lot of diseases, and that would be really great. And that's where his research is going right now. So who's the perfect donor? You want to be skinny, right? Because we all want to be skinny, and if it's related to obesity, you want to have a lean donor. That's one of our research. We're looking at what happens to the recipients from the donor. If you have a fat donor, do they get fat and vice versa. You want no chronic diseases, no infectious diseases, no predisposition to anything else, low TMA producing foods. Hang on, I'm not done yet. I'm not done yet. Okay, because this is becoming very important. The FDA has clamped down on this. They have called fecal transplantation a biologic, meaning it's a drug that has to go through all the drug development before it gets used. They are enforcing it for everything except C. diff. You are not allowed to do this to yourself, or we can't do it to you, to anything except C. diff, because they have something called an enforcement discretion. You really shouldn't do it for C. diff, but we're not going to go after you if you do it for C. diff. That's what enforcement discretion means. So what do? We have some dilemmas. Dr. Carey.
I have a dilemma.
We have a dilemma. Before we get to your dilemma, this is the thinker, one of 23 made by Rodin, and this is the Cleveland thinker on the south side of the Art Museum here, which you can see anytime you want. You see anything wrong with this thinker? This is probably his most famous sculpture of the thinker because of what happened here. You know what? Can you see it? Do you see it? Yeah. Were you there? You were there? Okay, let's sit down. There's a chair right there. Well, this is famous because about 6 weeks after the Kent State shootings, this was blown up as part of an anti-Vietnam War protest. So we were in the middle of a lot of things here. They decided not to fix the legs, just to prop it back up, and you can still see the statue right there. But what do we do? What do we do with this fecal transplant business? Well, some people have developed capsules. Maybe that would be a lot better. You get a capsule of freeze-dried feces and you eat them and you're all cured. And indeed there is a study out there that shows you can cure yourself with capsules. There's this company called OpenBiome. They have no IND, in other words, totally illegally, but they are have not universal donor. They're testing very rigorously for people and selling their capsules and fluid on the open market to doctors only, not to patients, for the money you see there. The Cleveland Clinic, so I looked into this, and the Cleveland Clinic made it very clear to me that the guidances by the FDA says we cannot use those capsules unless we are in control of the donor. We have to test the donor. I can't rely on a third party to do that. But what is happening is people are doing this themselves. And this is like the New York Times, right? The power of poop. People are doing it themselves, the do-it-yourself approach. What? I have to tell you, you should not do this. I'm strongly discouraging it because you will run into problems. You will run into a perforation. You will run into transferring a bacteria. You will run into big problems. Your recipient will hate you for life if they get a problem. You should not do this. Please don't do this. Enough,
Thank you very much.
Enough said.
All right. We have a round of applause. No, we really have to go.
I have one more thing to say.
No, we have to go. We have to go. Okay. You have a seat right over here. Over here. Question is answered. Yeah. Well, thank you, I guess.